Hello, Bukum. Can you hear me, Bukum? Okay, I think Bukum has some network issues, so I think I should take over until she gets back. Can you hear me?
Yes, we can hear you.
Okay.
Yes.
Good afternoon. So I think she was introducing the speakers. I really don't know where she stopped. Okay, I think she stopped on Dr. Uyedika Elonze. Then we have Mary Igwe, she's a pulmonary hypertension patient and advocate in Nigeria. Okay, so let's get on to the questions. So the first question, our first speaker, Dr. Emmanuel Nkampo. So there's a common misconception about hypertension and pulmonary hypertension being the same. Could you please clarify what pulmonary hypertension is?
Good afternoon.
Good afternoon.
Audible.
Are you back? Hello, Buku.
Yes.
Okay.
I'm sorry. I had network issues.
Okay, would you be able to continue? Your network better now?
Yes.
You're still breaking. We can hear you. Ibuku, we can hear you. You're still breaking.
Oh.
Okay, so I'll just take on continue. When your network is better, you would take over. Okay, so I was asking Dr. Emmanuel Nkampo a question. There is a common misconception about hypertension and hypertension being the same. Could you please clarify what hypertension is and highlight the distinctions between hypertension and the more commonly known hypertension? Thank you so much.
Okay. So hi, good afternoon, everyone. Can you hear me? Can you hear me?
We can hear you. Yeah, we
You
can hear you.
Okay, great. So, thanks for having me here. So,
You're welcome.
So the question was distinguishing between systemic hypertension, which is what most people call hypertension, and pulmonary hypertension. So if I'll start with just giving a simple explanation, the heart has two main functions. It pumps blood. There's a part of the heart that pumps blood to most of the body. We call that is systemic circulation. And then there's a part of the heart that pumps blood to the lungs. So the left side of the heart pumps blood to most of the body, also called the systemic circulation. And the right side of the heart pumps blood to the heart. So the commonly known hypertension, which in medicine we will call systemic hypertension, is distinct from hypertension involving the pulmonary system. I don't know if that makes sense. Elevated pressures in the vessels that carry blood to the hand, to the brain, to the eyes is what we call hypertension, or more specifically, systemic hypertension. Whereas elevated pressures to the vessels, in the vessels that carry blood to the lungs, is what's called pulmonary hypertension. So that basically is a simple distinction, and there are different cutoff marks and cutoff levels for defining the common hypertension and for defining what's called pulmonary hypertension.
Okay, thank you very much for that. Okay, so what are the different levels? What are the numbers? Like, in hypertension, we have a particular number to know this person is hypertensive. Then pulmonary hypertension, we also have a number to know this person has elevated pulmonary pressure. Please, what are the numbers?
Okay, yeah. So for hypertension, for systemic hypertension, the common cutoff used is a value equal to or above 140. That's what we call the systolic blood pressure, and or a value equal or above 90 for the lower value. That's what we call the diastolic blood pressure. Of course, hypertension is measured with a cuff put on the arm. Pulmonary hypertension, the most accurate way to assess pulmonary hypertension or pulmonary pressures is through what we call a right heart catheterization. Now, the most recent guidelines have recommended that pulmonary hypertension be diagnosed if the mean pulmonary artery pressure is more than 20 millimeters of mercury, or if the pulmonary vascular resistance is more than 2 Woods units. So I mentioned two things for systemic hypertension. First of all, how do you measure systemic hypertension or regular hypertension? Put a cuff on the arm. If the value is more than 140 on top or equal to or more than 90 below, that is hypertension. But for pulmonary hypertension, the most accurate way to assess that is through a procedure we call the right heart cath. And the numbers are a mean pulmonary artery pressure more than 20, or a pulmonary vascular resistance reading more than 2 Wood units.
Okay, thank you very much. Ibuku, are you back?
Yes.
Okay, so you can take over now.
All right. So I want to believe hold on, please. I want to believe that I'm audible and everyone can see me. Can we?
Yes, we can.
Okay, thank you very much, Ma. All right, so I'll be moving on to the next question for today's panel session. So, all right, so my question goes to Mary P. Igwe, who is a pulmonary hypertension patient and also a pulmonary hypertension advocate here in Nigeria. So I'd like to ask you, Ma, can you please kindly share your story, how and when you were diagnosed and your experience living with pulmonary hypertension here in Nigeria? You have the floor, Ma.
Okay, unfortunately, Mary hasn't joined. I sent her a message, but I didn't reply. Okay, but I also live with pulmonary hypertension, so I can also share my story.
Wait, before you proceed, let me just ask all of my questions at once, so you are able to like answer it all together. So I asked her to share her story and how and when she was diagnosed and her experience with living with pulmonary hypertension in Nigeria. Also, I'd like to ask you, has it impacted on your daily life? And what are the challenges that you face on a daily? And how can healthcare providers support you more? So, Miss Ayotunde Mishogun, you have the floor, ma.
Okay, so how was I diagnosed? I was diagnosed. Then I went
I'm
some
sorry,
10
did
years
I
ago.
lose you? I can't hear you.
Oh, can you? Okay. I said I had a congenital, I was diagnosed with congenital defect, ASD, with receptor defect, when I was about 3 months, 4 months old. And it wasn't closed, for reasons I don't really know. And 10 years ago, I went back to the hospital. I wanted to find a way to close the hole, and I was diagnosed with pulmonary hypertension. And after then, I was wondering if it was to be closed. So I went to different hospitals trying to know if the hole can still be closed and the pressure can go down. Unfortunately, I was told the pressure was too high. So yeah, that's how I was diagnosed. And challenges with hypertension in Nigeria. I think the biggest challenge for me is the isolation. I'm living with a disease that nobody knows about. When I was diagnosed with hypertension, I heard about it for the first time. So it's so isolating. A lot of people don't understand you. And the fact that it's an invisible disease, people can't really understand your symptoms. You're always fatigued all the time. When you cough a lot. People look at you and like, that's stigma. And also getting medications is very difficult in Nigeria, and we have very limited medications for pulmonary hypertension. Yeah, I think that's like the major challenge I have. Then I think how does it impact your daily life? It impacts your daily life because you can do like heavy normal day activities, things like sweeping. I don't sweep. I walk in. Yeah, I get really tired. I can't take the stairs. So yeah, that's how it affects my daily life. And I have to use drugs every day. Sometimes when my oxygen level gets so low, I have to be on oxygen. Sometimes I have to take oxygen at home or on the hospital. I think that's a major way to affect my daily life. I think that's major challenges. And that do I think healthcare providers can support more? I can healthcare providers support more support. I think healthcare providers, I feel in Nigeria, I just feel like it should be dedicated pulmonary hypertension clinic. Like most times when I go to clinics, I go for cardiac clinic or respiratory. But I think it should be pulmonary hypertension dedicated clinic, dedicated. It should be pulmonary hypertension specialist dedicated to this disease. It's a very complex disease, and I think we'll get better care if we get that in Nigeria. Yeah, thank you.
You're welcome. Thank you very much for that answer. I would also like to add one more question because we also have non-medics here, and I'd like to ask you, how can people generally, aside healthcare providers, help patients with pulmonary hypertension?
I think how people can help is they should be more open-minded, and I think you should not judge a book by its cover. So a lot of times you see somebody looking all well and not looking sick, and person say, I live with this disease, very deadly, very serious. People don't take it seriously. And I also think that also affects even when it comes to your diagnosis, because a lot of times you go to the hospital and people like don't even you can't breathe, and they don't believe it. So yeah, I think people should just get more open-minded and don't judge a book by its cover, especially people that have invisible illness. Just be nice. Just be nice generally, yeah.
All right, thank you very much, Ma. So we don't have Dr. Onyedi Kailonze on the call yet, but we do have Dr. Temitope Victoria Fakonda, who is a senior registrar at the Pulmonary Clinic here in Lagos State University Teaching Hospital. So my question to you, Ma, is how are patients diagnosed of pulmonary hypertension here in Nigeria?
Good afternoon, everyone. Apologies for any background. I'm actually on the move. Yes. So how is pulmonary hypertension diagnosed in Nigeria? Okay, so we've had pulmonary hypertension defined. So it starts with symptoms. So usually people with pulmonary hypertension commonly present with difficulty breathing, which could initially be with exertion or strenuous activities, and that could get worse. They could have episodes of cough, fatigue. Then also there are some disease conditions that are associated with pulmonary hypertension. For instance, I'm a pulmonology trainee, and generally, pulmonary hypertension actually has about 5 groups depending on what the underlying cause is. So in my own practice, usually we are involved with the group 3 and 4. So group 3 pulmonary hypertension are people that develop pulmonary hypertension as a complication of a chronic lung problem, something different, for instance, COPD or a chronic lung disease or some chronic problem that makes them have low oxygen for a long time. And then the pulmonary hypertension occurs as a complication. So usually in those category of people, there's already something that we're making us suspicious. So, but for all cases of pulmonary hypertension, when we begin suspecting from symptoms, so the basic things we usually do is to have them do an echocardiography, which is an ultrasound scan of the heart, because as was defined, pulmonary hypertension usually puts some strain on the right side of the heart. So there are some things that will be seen on the echo that could help. And then there are some other supportive investigations that are still available and non-invasive, like ECG, electrocardiogram, and also there are some cardiac markers, so blood tests for, it's called N-terminal proBNP or BNP. So these are some cardiac tests that can help while evaluating for pulmonary hypertension. However, the gold standard test for pulmonary hypertension is called a right heart catheterization, and which is now actually available in Lagos at my center, that's Lagos State University Teaching Hospital. We actually have a cardiac catheterization lab that's it's young, it's little over a year or less than a year old, and we've had a lot of right heart caths done. The only challenge with that is the cost, because it costs more than ₦500,000 or so. But that's ultimately the gold standard, because it also helps you to stratify. You know, when the doctor was defining pulmonary hypertension, he mentioned the pressure, he mentioned the pulmonary vascular resistance, he mentioned other things. So it's usually when you do a right heart cath that you can be able to identify these things and properly classify the individual so that you can prescribe the correct treatments. Yeah, thank you.
Thank you very much, ma'am, for that explicit answer. So, like you said earlier, when diagnosing pulmonary hypertension, we take history of the symptoms and the clinical presentation. And like you rightly said, the gold standard for diagnosing pulmonary hypertension is the right heart catheterization. And you mentioned as well that the only center that has it here in Nigeria is at Lagos State University Teaching Hospital. And that brings a lot of challenges.
Sorry, that's not the only center that has it, but that's like the government center in Lagos. Yeah. So there are some private facilities, yes, that have that.
Okay, so the only government
in Lagos.
The only government facilitated center that has it here is in Lagos State University Teaching Hospital. Am I correct, Ma?
Yes, in Lagos, because I'm aware that, in Abuja, in some other parts of the country, there are some private centers. So I think it's still the only government hospital in the country, actually.
Okay, so that brings in my next question, that there will be a lot of challenges, such as assessing this center because of price and also because of the fact that it's the only one that is facilitated by the government. So how do you think that we can address this issue? What are the steps we can take to mitigate this problem?
Okay, so really it's basically advocacy and trying to get well-meaning citizens know about the condition and develop an interest in helping, because the only way the testing will become more affordable and readily available to people is if there's extra funding. Because I mean, the center is a public-private venture, so it's there's some private involvement. But if we have organizations or groups that develop interest and would help to fund the pulmonary hypertension program or clinic, or if we have access to grants, so those are usually the ways in which very expensive procedures or investigations can be accessible to the common man. So funding from organizations and support groups.
All right, Ma. Thank you very much. So you mentioned funding from international organizations and support groups or associations interested in this medical condition. I would like to throw this same question to Dr. Emmanuel Nkamfor, that these challenges that are faced by the patients, of course, we have financial constraints, as accessibilities, and also lack of awareness. How can we address these issues aside what Dr. Fakmunda has mentioned? Dr. Emmanuel Kafawa, are you with us, sir?
Yeah, can you hear me now?
Yes, I can.
Okay, so when you talk of a lack of awareness, you were talking about a lack of awareness on the part of the population, and also a lack of awareness on
Yes.
the medical system to the existence of the problem, how to get it tested, confirmed, treated. And then, of course, there are other issues you spoke about in terms of funding. Let me start from the funding. Yeah, funding is a big issue. The procedures are not cheap. Unfortunately, the hardware used to do a right heart cath of course, is not manufactured in Nigeria, and with our exchange rate going south, everything sort of goes with it. But I know that there are countries that, we talk about India, countries that have programs that subsidize these investigations, or if we had, let's say, a more expansive national health insurance system, that would probably provide better cover for that. In our hospital at First Cardiology Consultants, we have a foundation, a Healthy Heart Foundation. And I think I'm aware of other foundations, Kanu Heart Foundation, that basically sometimes pays part of the bill for patients when they need to get these tests done. So I'm sure there's a way to expand this model to cover more people. In terms of the problem of awareness, I feel that we probably in Nigeria need to put in place a policy, a health policy that would have children who have some of the symptoms that one of the earlier speakers had, children who have complaints of breathlessness, adults who have similar complaints of breathlessness, whether sudden or progressive, or who have abnormalities, certain abnormalities in ECG, or who have a family history of pulmonary hypertension, have um, there probably needs to be some protocol clearly drawn out that will have these groups of people referred early for tests to of course to confirm this abnormality, confirm if this abnormality is present. If that is done, probably we'll catch more cases earlier. We'll catch cases at the point where treatment will probably will be easier, more effective. So that's probably what I have to say about that.
Okay, thank you very much. I think the book is off again. Okay, so also I have another question for you. She didn't have that. Let me fix that and answer. Okay, like what are the typical symptoms of pulmonary hypertension? That's Dr. Emmanuel. And how can we differentiate these symptoms from those associated with other respiratory conditions such as asthma and COPD?
Okay. So, unfortunately, many of the symptoms of cardiac conditions are similar. So, if a patient has problems with the left side of the heart, if a patient has problems with the valve, if the patient has with the heart valve, if the patient has problems with the electrical activity of the heart, the patient may have very, very similar symptoms to what a patient with pulmonary hypertension, that's elevated pressures in the vessels of the lungs. Sorry, I'm trying to water it down because I think there may be some lay people around. Um, um, so cardiac symptoms generally from several causes and from several abnormalities are similar. But so the symptoms that people will present with would be usually the first thing would be a change in the amount of activity the person can tolerate. So, or could previously tolerate. So that's always very important to define what the person could do before and the change that the person has noticed. If somebody previously could climb up 2 or 3 flights of stairs without a thought, and then the person notices that climbing up the first flight of stairs, but he or she is extremely breathless. That's a change in effort tolerance or exercise or activity tolerance, if I'll use a lay term. After that, some people may experience a cough. And of course, as I mentioned before, cough can also be found in many other conditions, both lung conditions and heart conditions. These are the symptoms that usually started. With time, the patient may develop. Sorry, I just want to lock the door so noise is in the leg. And when the condition has gone on for some time, there may also be swellings in other parts of the body, swellings of the tummy. Then some patients with this may also faint. Fainting very often will happen during activity. So person gets up, tries to run, tries to walk fast. Suddenly they notice they're dizzy and then they lose consciousness. Those are the commonest symptoms. So differentiating pulmonary hypertension from chronic lung conditions, from lung conditions that have been on for a while, is probably not the easiest thing to do because many lung conditions that have been on for a while can cause pulmonary hypertension. One of the earlier speakers mentioned that I think it's class 3, that patients in class 3, class 3 pulmonary hypertension can have patients with classic are patients who have lung conditions that have led to problems with the pressure in the vessels of the lungs. So, but usually when you know that, okay, so the symptoms would be maybe similar, but the things that would make somebody think that there is an extra problem happening with the um, with the with the pulmonary system would be leg swelling, so common for people who have um, long-standing lung conditions, to faint, especially with activity. The abdominal swelling of the tummy, um, that probably will suggest that it's not just a lung condition, but the right side of the heart is under some strain and is resulting in water accumulation, in fluid accumulation in the parts of the body that take blood back to the right side of the heart. So of course there are several things that we'll see with examination that will suggest that what you're dealing with is more likely to be pulmonary hypertension associated with um, dysfunction of the right side of the heart compared to a plain lung condition. I'll just quickly run through this. I know that we have a lay audience here. So from examination, as I mentioned, there will be swellings of the legs. There will be swellings. There may be swellings in the tummy. Sometimes looking at the neck, there may be pulsations in some of the veins of the neck. Now the veins of the neck are connected with the right side of the heart. So if pressures in the right side of the heart are high, we find that the veins of the neck, they have a characteristic appearance or pulsation. And then examining the heart, the right side of the heart, there'll be a thrust from the right side of the heart that we can feel. We call that the left parasternal heave. There may be palpable heart sound, particularly the second heart sound, the pulmonary component of the second heart sound, and there may be murmurs. I just don't want to go into too much detail because we have lay people here. So to just summarize what you asked me, based on symptoms, it may be a bit difficult to differentiate. But if somebody develops swellings of the leg, swellings of the tummy, or if somebody faints with activity, that usually suggests that this is more than just a chronic lung condition. There's something extra happening. And then there are examination findings, probably that's definitely more relevant for the medical people here. That may also suggest that it's more likely to be pulmonary hypertension compared to just a chronic lung condition.
Okay, thank you very much for that. Thank you so much. Ibukun, you're back. Are you back?
Yes, I am. I'm sorry again. Network issues have me on chokehold. So, I'd like to throw this question out to everyone, both the panelists and the audience, that what treatment options do we have here for pulmonary hypertension in Nigeria? What treatment options are you aware of here in Nigeria? So anybody that wants to answer? Can we indicate by show of hands? Do you have anybody on the call that wants to answer? Oh, okay. We'd like to hear you, sir. Dr. Emmanuel.
Okay, so I'll try to give an overview. As one of the earlier speakers mentioned, the treatment for pulmonary hypertension really depends on the type of pulmonary hypertension or the class of pulmonary hypertension the patient has. The way we will treat somebody who has what we call class 1 pulmonary hypertension, Because class 1 pulmonary hypertension, which is pulmonary arterial hypertension, is different from how we will treat somebody who has a problem with the left side of the heart causing problems with the right side of the heart. Bit different from how we treat somebody who has a chronic lung condition leading to pulmonary hypertension. Different from how we treat somebody who has a clot that has gone to the lungs that that has become hard, not dissolvable, and now in that scenario leading to increased pressures. However, there are some things that are basically common to all to all conditions. Patients who have pulmonary hypertension should ideally be enrolled in an exercise program, a cardiac rehabilitation program, that will allow them that will aid them in maintaining their strength and their independence for as long as possible. All patients with pulmonary hypertension who have low oxygen levels in normal air, in room air, will benefit from using oxygen supplementation for several hours during the day. All patients who have pulmonary hypertension, you want to avoid things that put extra stresses on the heart. So for them, you probably try to recommend that they eat healthy, they take a low salt diet, they should avoid excessive weight gain. For all these patients, you would want to do your best to prevent them from having bad viral or bacterial lung infections that will add extra stress to their system. So ideally, they should all get vaccinated. And I think that is something that we can do, maybe a low-hanging fruit in Nigeria, something that we can do, something that we can do that will hopefully prevent many of the reasons for the acute deterioration of patients who have pulmonary hypertension. When you go, and then of course, if patients have leg swellings or tummy swellings, they may, in all the groups, they may benefit from diuretics, water pills that will make them pee out the extra water. But then the treatments generally are specific to the different causes. If patient has the first class of pulmonary hypertension, patient will need medication to help to relax the vessels in the vessels of the lungs, and also retard some of the changes that are happening in those vessels that are leading to the problem. Patient has class 2 pulmonary hypertension, the patient needs to get treated for the problem with the left side of the heart, and that may be medication, or in some cases that may be surgery if there is a problem with the valve. Patients who have class 3 pulmonary hypertension, essentially the treatment will be treatment of the primary lung condition. They will most likely require oxygen therapy, as I spoke about, home oxygen therapy. They will very likely require, especially if there is there is a restriction or an obstruction to how freely they can breathe, they may need inhalers that will open up their airways, make it easier for them to breathe. And then they may also require cardiopulmonary rehabilitation if they have conditions associated with lots of sputum, lots of secretions, essentially to make them more comfortable. For patients who have class 4, of course, patients who've had who've had recurrent or a previous pulmonary embolism event, but the clot did not resolve, and that's causing obstruction. The most effective treatment is surgery to remove that obstruction caused by the clot. And then for the last case, many times, for the last class, many times we just give medication to medication, some medication is still used to relax the airways, but the effectiveness, sorry, to relax the vessels of the lungs, but the effectiveness of that is it's not that great. So this is just a superficial overview. I'm sure any of the other panelists may want to give more details in any of these areas.
All right, thank you very much, sir. I'd like to ask if any of the panelists
sorry,
I
wanted to just say something about that.
Okay.
Sorry, I want to ask a question to the doctor about the treatment for especially for class 1 pulmonary hypertension. So I know that there's 3 pathways for pulmonary hypertension, PAH, pulmonary arterial hypertension, and we have insulin receptor, I think nitric oxide, and we have prostaglandin. I think in Nigeria, the only treatment we have for that is for the insulin receptor, which are like the Bosetan and Brisitan, and we have the nitric oxide, which is sildenafil and tadalafil. I just wanted to confirm with these 2 treatments, even though we don't have prostaglandin in Nigeria for pulmonary arterial hypertension, do you think for the 2 pathways treatment, which is maybe treating nitric oxide, for nitric oxide, which is sildenafil, and for the insulin receptor antagonist, which is Bosetan and Brisitan, do you think these 2 treatments is enough for patients with pulmonary arterial hypertension alone?
Well, this treatment is a good start. I won't say it's enough. I mean, as you know, the guidelines would suggest that for patients who have class 1 pulmonary arterial hypertension, they should get a right heart cath, and they should be tested for vasoreactivity. Most people, so basically what this means is, there are different classes of, sorry, I keep on remembering that, I keep on being cautious of the fact that there are some people here who may be lay people. So there are different types of pulmonary hypertension, and we're just trying to figure out what works best for each class. For patients who have class 1 pulmonary hypertension, ideally they should get this right heart cath and then be tested for vasoreactivity. Unfortunately, just about 5 to 10% of people will have vasoreactivity, and it's specifically defined. And for those people, calcium channel blockers, nifedipine, amlodipine, diltiazem, high doses of that sometimes may produce a dramatic response in these people. Unfortunately, not all people will show this positive evidence of vasoreactivity, and not all the people who appear to show evidence of vasoreactivity during the right heart cath will show a significant symptomatic response when they're put on calcium channel blockers. The guidelines will suggest that in both groups of patients, we should go next to the prostacyclin agonist analogs, and then the endothelin receptor antagonists. And generally, that is the next step. Many times, combining these 2 agents, or at least combining 2 agents, which may be, as you said, sorry, I meant to say, so guidelines will suggest that if they don't respond to calcium channel blockers, or you should go next to using the other agents, which are the prostacyclin analogs or agonists, the endothelin receptor antagonists, and then the phosphodiesterase type 5 inhibitors like sildenafil. I mean, the guidelines says that you combine 2 of them, and these guidelines that I'm aware of, I don't mind being corrected. Combine 2 of them initially, and sometimes you may need to eventually use all the 3 if there isn't adequate response. The patients that I have seen with pulmonary hypertension, type 1 pulmonary hypertension. Many of them have had a reasonably good response to these agents. And when I talk about response, we're talking about an improvement in their 6-minute walk time. We're talking about some improvement in the echocardiography parameters. We're talking about improvement in the biochemical markers for heart failure, like NT-proBNP and some other indices. So I've seen quite a few people who've had improvement symptomatically and then also by these more objective testings. But there are some people who, after some time, their response to this will decline as the vascular abnormalities worsen. There are surgical interventions and patients who can get them. So, to answer your question more specifically, I think that if most patients who have, who are, I feel that we should get improved symptomatic status, improve objective markers by imaging, by biochemistry, and indeed longevity, reduce mobility, reduce hospitalization, and and improve length of life. Definitely, it will not be enough for everybody, but I think we can start with what we have here.
All right, sir. Thank you. We have a question from someone who is listening, and he asks that does pulmonary hypertension get worse to a higher stage where it gets critical, that if medication isn't adequately taken? Then he has another. I don't know if I got that first question correctly. Does pulmonary hypertension get worse, like to a higher stage where it gets critical if medication isn't adequately taken? Okay. Then another question from Samuel Friday is it a must we get tested for pulmonary hypertension even if we don't notice, even if we don't notice or have the symptoms?
Okay.
I don't
So
know
I'll answer
any
these questions.
of our speakers would like to take. Oh, okay.
Okay. No. Let somebody else answer. I've been talking too much. Yeah.
I don't know if any of our speakers would like to take this question.
Hey,
So pulmonary hypertension is not something that you would want to routinely screen, like population level screening, except for people that are particularly at risk. And most times, like based on the 5 groups that they've been grouped into, so it's not something that if you don't have, it's not something that so there have to be the symptoms first. It's the first part of the assessment. So if you don't have any problems with breathing or anything, then it's not a kind of condition that or community level based, then we go around screening people for pulmonary hypertension. No, it's not necessary.
Hello, Ma. There's also another question. Hello.
Okay, I just read through about it getting worse. Yes. So especially in our environment where, because of the lack of awareness also among healthcare providers, so sometimes a lot of patients present when there's some problems with the right heart, so right heart failure that we call pulmonary. So yes, pulmonary hypertension can get progressively worse if treatment is not started on time, and even when on treatment, compliance as well. And even sometimes, despite compliance, it may still progress, similar to what we see in heart failure. But it's a condition that requires appropriate specialist intervention and management. So at different levels of severity, there are treatment options that are still available. So it's not something that the person would manage on their own. They will be work in close partnership with their clinician, and then the appropriate treatments will be escalated depending on the severity. Thank you.
Thank you very much, Ma, for answering. Mr. Samuel Friday, I hope you have gained clarifications on the questions that you have raised. I noticed Dr.
Okay, thank you very much. Ibuku, are you there?
Yes, I am.
Okay, yeah, I also wanted to introduce that some of our speakers joined
Dr.
Oyedika Iloze, then Mary P. Igwe joined now. So I think we can allow Mary P to answer the question. I already answered it actually, but she can also answer it. It's
All
good to
right,
get
so
different.
welcome to discussion on living with pulmonary hypertension. I would like to ask you, Ma Mary P. Igwe, can you please kindly share your story, how and when you found out that you had pulmonary hypertension? What are the challenges that you have faced so far? And how has it impacted on your living? And how do you think healthcare workers can help people with this condition? You have the floor, Ma. Can you hear me? Hello?
Hello, Mary. Okay, she's not
Okay.
she
So
can
let me just go to Dr. Onyedika. While we use that to wait for Mary to connect. So welcome, Dr. Onyedika. It's such a pleasure having you on this platform. Thank you for joining us. Can you please unmute so we can hear you speak?
Sorry, I didn't realize I was muted. Thank you so much for this kind invitation. I think Ayomide invited me, and it looks like you guys are both co-moderators. So I want to thank you for what you're doing, which is really advocacy, and advocacy, I believe, builds strong institutions, and strong institutions build strong nations. So thank you so much for the work you're doing. I joined when the other doctor was talking about pulmonary hypertension, so I wasn't sure how far you had gotten. But I wanted to know if you could just. It started by 9, right? Not 8. Am I too late? I wanted to make sure. What time did he start?
By 2 p.m. Nigerian time. So you have a question.
So I just want to make sure I wasn't too late, because I wanted to.
Tad bit late, so but then we have a question for you to answer.
Yeah, absolutely. What's the question?
Can I go ahead?
Please.
Okay. So pulmonary hypertension is.
But hold on, sorry.
All right.
Ibuku, sorry for cutting you in. I think a lot of the speakers have also answered a lot of the questions about the 5 different groups of pH according to their cause. A lot of the speakers have answered a lot of that question. So I don't know if maybe we should ask about maybe second question, because a lot of the speakers have already answered so much about that question during their own when they're talking.
Okay. So let me just ask. We have previously discussed about the treatment for pulmonary hypertension. So I'd like to know, I guess you are not in Nigeria, so I would like for you to,
Okay, Dr. Oyedika, sorry, I hope I'm pronouncing it well. Okay, so we already discussed about the 5 different WHO for pulmonary hypertension according to their cause, and that was a question we meant to ask you. But since both speakers have already discussed about it, I just wanted to ask that what group underlying associated disease, what pulmonary hypertension group is the most common?
Yeah, so that is actually a great question, and even without your question, that was going to be the main point that I was going to get across. So WHO Group 2 pulmonary hypertension is the commonest. And why is this important? This is important because WHO Group 2 pulmonary hypertension is due to left heart disease. So it may be someone who has a bad heart, bad left heart, maybe from heart failure, or maybe a previous heart attack, or maybe some valvular heart disease. It's also important because this group 2 pulmonary hypertension, you do not need any of the specialty medications, like sildenafil or bosentan or the prostanoids. If you look at the chart, you can see that WHO Group 2 pulmonary hypertension is actually responsible for as much as maybe 55 to 65% of all cases of pulmonary hypertension. Now, the other ones, which are like Group 1, Group 3, Group 4, and Group 5, actually have what we call orphan disease status, which means that they are so rare. And I think the question from the other participant was, should we all get screened? Should we all get tested? For those other ones, rare forms of pulmonary hypertension, because the incidence and the prevalence is so low, population screening will not really be effective. But group 2 pulmonary hypertension is by far the commonest. And that is something that we see a lot in cardiology.
Okay, thank you very much. I just wanted to confirm, is it group 2 is the most common? Is it all over the world or just a particular part of the world, or all over generally? Is it the most common?
So all over the world. And that's because group 2 is basically, so heart disease is a disease of aging, right? So as people get older and they have all forms of heart disease, eventually they have some form of group 2 pulmonary hypertension. Group 1 is normally seen in like maybe some congenital diseases, some autoimmune diseases with HIV. Those are not quite as common. Now, if you get into epidemiology, most of the data we have on incidence and prevalence is from the rest of the world apart from Africa. There was a paper that we saw that I looked at early this year from South Africa where they looked at the incidence of pulmonary hypertension in pregnant women. And even in that scenario, many of the women had prior left heart disease. So it is right that there may be some changes in the epidemiology in West Africa and Sub-Saharan Africa, but that is data that we need to collect and report. I don't know if I answered the question correctly, Tunde.
Confirm. I know when it comes to group 5, people living with sickle cell disease can also have, and I think when it comes to pulmonary hypertension, as the session said, that 30% of people living with sickle cell disease might have pulmonary hypertension. But I mean, sickle cell disease is very common in Nigeria. But unfortunately, we don't have that awareness in the sickle cell society. So I just wanted to confirm about the connection between sickle cell and pulmonary hypertension.
So this is a really, really, really good question. And this is the reason why we are doing what we're doing, right? So because here in we have a paper that actually is going to be published tomorrow in a couple of days, and I'm talking about cardiovascular complications of sickle cell. If you look at the Nigerian literature, a lot of people, mostly in Enugu, University of Nigeria, have done some studies on prevalence of pulmonary hypertension in sickle cell. There's a guy called Ogwanobi who has done a lot of that work. It is underdiagnosed, that is correct. And it is very important to think about that because unlike 20, 30 years ago, when most of the sickle cell patients died, we now have patients with sickle cell who are living into adulthood. So these pulmonary complications are getting more common. For patients with sickle cell who have suspected, the guidelines, many of them recommend at least a screening echocardiogram at some point, then looking at some echo criteria. And if they are positive, then you can now go ahead and get it like a right heart cath. But you are correct. It is a growing problem, and it is a sort of a unique problem to patients of African ancestry who are more likely to have sickle cell, and it's something that we should definitely create more awareness about.
Okay, thank you very much. Thank you so much. Ibuku?
Yes, I'm here.
Okay, so sorry, let me just ask one last question to the doctor.
All right.
Okay, what are the disparities in the treatment of pulmonary hypertension between developing nations like Nigeria and the developed world?
I think you really researched well before getting me here. I think you're asking all the correct questions. I think the biggest disparity that I see is has to be, first of all, grounded in understanding the epidemiology of pulmonary hypertension. As many of you people on the call may know, Africa has the youngest population. The mean age in Africa is about 19 to 20, 21, a very young population, unlike sort of like Western Europe, North America, and Asia, where the mean age is about 50, 60. So the main disparity I see is in diagnosis and etiology and cause, sorry. So in sub-Saharan Africa, it may be a different type of pulmonary hypertension. I expect there to be more pulmonary hypertension from congenital disease that may or may be diagnosed or uncorrected, and also from rheumatic heart disease, which remains a common cause of heart disease. So I think having the expertise with echo, ECG, and cardiac manpower and pulmonary manpower to diagnose this is a huge disparity. And then when it is diagnosed, because it's such a multifaceted disease, it's not just one person, which is why you can see on this call, there's cardiology, there's pulmonary, there's patient advocacy. Getting the patients to the right specialty to get appropriate and timely care is a huge disparity. That's what I would say would be the big disparity. Now here, like the rest of the world, there's still disparities, but it's more in terms of it's not quite as stark because there's a little bit more facility to get the patients where they need to get diagnosed and treated.
Okay, thank you very much. Ibuku, you can continue.
All right. Thank you, Miss. I don't know if I'm audible. Am I? Okay. My question still goes to you, Doctor.
I think Mary is now back on the call, so you can ask her. Mary, are you there? Can you say hello? Mary?
Hello, can you hear me?
Okay.
I'm here.
All right.
Okay.
Welcome, Mary, to the meeting. We're so glad to have you here. Can you hear
All
us?
right,
Please
thank you very
respond.
much. Yes, I can hear you.
All right. So Mary P. Igwe is a pulmonary hypertension patient as well as an advocate for pulmonary hypertension here in Nigeria. And so we'll be asking her this question. She's supposed to be the first to answer, but I guess due to one circumstance or the other, she was not able to make it and she's just here. So I'd like to ask you, Mary, that how has it been?
See what you wanted to see. Oh, I've been doing quite okay.
All right. So I'd like to ask you to kindly share your story. How and when did you find out that you had pulmonary hypertension? And how has it been living with pulmonary hypertension? What are the challenges that you have faced so far? And how do you think healthcare providers can solve or mitigate the problems of pulmonary hypertension?
All right. I've been living with pulmonary hypertension for
Hello,
about.
Mary, you have the floor.
Hello, can you hear me? Hello.
Yes.
Okay. So I've been living with pulmonary hypertension for 7 years now, and I was diagnosed medically through a right heart catheterization, that is RHC. Hello, can you hear me?
Yeah, you can go on, Mary. We can hear you. I can hear you.
Yes.
Okay. So I've been doing quite okay from the medications available for now. Although the Nigerian system of health system is not all that good, so I've been doing quite okay for now. I actually found out that I had pulmonary hypertension after I had a series of symptoms that has to do with extreme fatigue. I had breathlessness. I had a lot of wheezing that could because before I was diagnosed, I was asthmatic. I'm still asthmatic though, although it was very serious and different from the typical asthma asthma attack that I usually had. And then I just knew that I had to investigate on that. I had to work with my doctors to find out what was actually wrong with me. That was 10 years ago. It took me about 2 to 3 years to be medically diagnosed with pulmonary hypertension. So after I was diagnosed, I was placed on medications to help slow down the progress of the high blood pressure in the arteries connecting to my heart. So, is there any other question that I'm not asking, please?
I asked that how do you think healthcare providers can actually solve this problem?
That would be a very difficult question to answer because right now the Nigerian medical system is poor.
Can you increase your volume or put the device close to your mouth so that we can hear you?
Okay. Hello, can you hear me?
Yes, much better. Thank you.
All right. Right now, the medical system or the health system in Nigeria is not so good. We have limited or short on available medications in Nigeria. Not everyone can afford the medications needed to treat or needed to manage pulmonary hypertension in Nigeria. So making these medications very affordable for the less privileged or for those who can't afford it afford these medications should be at least the first step to helping with the. Hello, please can you rephrase the question? The last question you asked me.
I said, how do you think healthcare providers can solve the problem of pulmonary hypertension? Like, what can they do to help patients living with pulmonary hypertension? Do you get it now?
Yes.
Hello,
yes.
Mary.
Hello, can you hear me? I
Hello,
can hear
Mary.
you. Yes, I can hear you.
Mary, are
Hello.
you there?
Yes, I can hear you.
Okay.
So I think the first step should be to explain to their patients what pulmonary hypertension is all about, because a lot of medical practitioners and a lot of healthcare practitioners do not actually explain to these people, to patients, to people suffering from pulmonary hypertension, what they're actually going to face or what they're actually facing, because most medical practitioners don't even have a full knowledge of what pulmonary hypertension is all about. I've visited some medical doctors that when I ask them some questions, they don't give me, it's as if I'm even more knowledgeable than them. They don't give a very convincing answers to these questions, because they just brush it up. They make it seem as if it's a very, very normal thing to have pulmonary hypertension. They make it seem like it's not a big deal to have a pulmonary hypertension. So first of all, letting these patients know what pulmonary hypertension is all about, making more research about pulmonary hypertension should be the first stage. Hello.
Please continue speaking,
Hello,
Mommy.
Mary.
I hear you.
Okay. Making research about pulmonary hypertension should be the first, another stage of handling pulmonary hypertension in patients. And then I think that's all for now. If I get some other points, I'll let you know.
All right.
So I just want to say something about what Mary said. I think what she said is very important. Like, you can't just diagnose people with pulmonary hypertension and just let them go. It's a chronic disease. You don't provide a bit of resources and a bit of knowledge. Just the people, they have pulmonary hypertension, bye-bye. It's a very complex, complicated disease. I think, it's very important, like when people are diagnosed with pulmonary hypertension, you should provide a bit of resources about how to live with this disease, how to cope with this disease. Like Dr. Dr. Emmanuel said, like how to eat, like what to eat, how to live, like how to reduce salt intake, how to also work on reducing or managing your fluid retention, all those things. I really understand that. I think, but we just in Nigeria, just say you have hypertension, just write it down, buy this medicine and bye come for appointment.
Exactly my point. Exactly my point. Medical doctors, they don't even help matters at all. They just allow the patient to find a way, like just work on it. I don't know. They are supposed to give advice. They are also supposed to, aside from medication, they're also supposed to give counseling, inform you, let you know about the condition that you're having, explain to you in more details. But these days, medical practitioners, they don't even have time to explain in details to their patients.
Okay, so thank you very much for that. Do we have any medical practitioner that want to talk on that? Want to say anything about that?
Yeah. If it's okay, I can make a comment. Is that okay?
Yes, it's okay.
Yeah, very okay, please.
So I think that for the rest of the conversation, I think we should focus on I'm going to focus on pulmonary arterial hypertension, which I think is the focus here.
Yes.
I think that we have to be kind. We have to be a little kind to the physicians. I think that this is an orphan disease that needs a lot of people who have expertise in it. This is
Exactly.
not. I would be surprised if a general practitioner knew a lot about pulmonary hypertension. I would be shocked. And this is not a uniquely Nigerian thing, right?
Exactly.
Even in England, in most of the the rest of the countries, these patients there are people that are known for this, right? So when physicians get a patient like this, they send them to those people who have expertise in this, right? I think that is something that would really help. I think that we have to be a little kind to the physicians who are practicing in Nigeria, who daily go through so much. They have to surmount a lot, even to keep their practices active. So that's one thing I would say. I would say that in terms of from the Nigerian perspective, I think that we need data on pulmonary hypertension. Who are the patients? How many are there? How do they present? So that is something that I think that we, as everyone on this call who is in advocacy, we may not have our physicians do exactly what we want them to do. They may not know, but we can at least guide them, right? In terms of, we need data, we need registries of who are these patients. We need a Nigerian registry to know who has pulmonary hypertension, how did they present, and what are they on. The other reason I wanted to say is that the medications for pulmonary hypertension, at least here, has what we call a REPS program, which is like a risk evaluation and mitigation strategy system, because many of the medications like macitentan, ambrisentan, the endothelin receptor antagonists, if you're a woman of childbearing age, you need pregnancy tests while you're on them because they can affect a baby, right? So these are not things that regular physicians who are practicing should be involved in, right? Which is again why we need those specialty physicians who are known, right, in Lagos, in Ibadan, in Lokoja, Abuja, or Jos, or Enugu. We need to know who the experts are so that when we get this patient, we send them to them and they will take care of the rest. So that was just my little submission on that issue.
Okay, thank you very much for that. So in between, you can ask general questions.
Okay, we have a question in the meeting chat box. I'd like to direct
Ibuku?
it to. Yes.
Okay, let me just go on with that. Okay, so
Can you hear me?
therapies. Okay, are you there?
Yes, I am.
Okay.
Okay, so I said we have a question in the chat box, and I'd like to direct it to Dr. Oyedi Kalonze. Goes sotatercept has been tagged a breakthrough treatment for pulmonary hypertension. What's the progress achieved from the trials, and what's the possibility of Nigeria assessing it once commercialized?
So that's a really good question. And I think whoever asked that question is clearly and definitely keeping up with the literature. So here's the thing, right? If you look at all the contemporary clinical trials for pulmonary hypertension, they have a surrogate, which is the 6-minute walk test, right? Which means how far are you able to walk on the medication, which is good. But in cardiology, traditionally, our gold standard, we like medications that make people live longer. The unique thing about sotatercept is that all the other medications were basically opening up the vessels. So they did not affect the natural history of the disease. But sotatercept seems to do that. So there is one major trial called the Stella trial that was released, I think it was published in New England in January, February, or March of this year. And the medication does not yet have FDA approval. It does not have FDA approval. That's the Food and Drug Administration. But I think one important thing about that medication is that it's subcutaneous. So it's not oral. It's administered subcut every 3 weeks. Normally, when medications have a lot of that, there's a lot, it's not as easy as commercializing it and bringing it to Nigeria. It has a lot of cousins. You know, what is the apparatus for injecting it? Is it a one-time, is it like a regular, is it a regular, subcut injection? Does it need to be frozen? Does it need to be refrigerated? Who gives it? Is it the healthcare provider? Is it the patient? How do we monitor the side effects? So it's not FDA approved yet. We expect it to be very soon, but it's not yet. So I think it's an option. It's better than the options we have, but I don't know if it's something that would revolutionize the treatment per se. I don't know if it's that option.
All right. Thank you very much for answering that, Dr. Inoza. I don't know if any of our speakers also have a contribution to us answering that question. Dr. Fakonda, Dr. Emmanuel Nkafo. Do we have any other contributions that said concerning the question raised by Olajide Olabi? I'll take that as no contribution. So I'd like to ask Dr. Fakonda, are you still on the call with us, ma? Hello, ma.
I am. It's just I'm trying to get a quiet place. Okay.
Oh, okay. So you mentioned earlier when I asked you a previous question that getting grants from international associations and support groups and group institutions that are interested in pulmonary hypertension can go a long way in mitigating the challenges faced by patients who have pulmonary hypertension. So I'd like to ask you, how can the healthcare system and professionals around the globe work together to improve access to care for patients with pulmonary hypertension worldwide, not only in Nigeria, across the globe this time around?
All right. Thank you. I think that is already something in existence. I mean, that's why we have guidelines that guide the management of conditions worldwide. So, but bringing it back, I mean, we've talked about data. So I think the primary issue for us in Nigeria is when it comes to pulmonary hypertension, especially group 1, the PAH, we're still limited in data, partly because for PAH in particular, it really needs right heart caths to really confirm the diagnosis, and it's largely a test that's still very quite inaccessible to most of the patients that we may suspect have it. So most times for these international collaborations and things,
Hello, ma.
sorry, I'm sorry, your call came in.
Oh, okay.
So I think what I just want to emphasize is that for us, we still need a lot of resources in actually diagnosing PAH. And I think for now, that's the international collaboration or aid that we need for more patients that we suspect to be able to get the diagnosis. More like right now, I think there's a need for us to have a registry for our PAH individuals, then before we start talking about medications, because for now, I mean, also the population, the prostacyclin-based medications, we don't even have access to that yet. So talking about sotatercept is still quite far-fetched for us here. So I think our goal here is to improve how we are able to diagnose these patients, and then we can, and the more we are able to recognize this group of patients, then we would definitely work on them having access to the required treatment.
All right. Thank you very much, Ma. Okay, so one thing she emphasized on is having enough resources, and in my own opinion, I feel it is quite necessary that before we decide to take a step in line to reduce or help reduce the rate or help solve problems of patients with this disease, we need to know the number, the data of the patients that we are working on. That would give us a large insight, because most of the times, even when we hear about pulmonary hypertension or want to know the incidence of the epidemiology, it is based off another country's data or another continent's information, not even here in Nigeria, and also as a whole, not just in one of the developed countries, but worldwide. We actually need registry of patients who have pulmonary hypertension. Okay, so I'd like to ask Dr.
Sorry, I just wanted to ask Mrs. Dr. Fakonda, sorry.
Okay.
So I wanted to confirm. So it's, you say like hypertension is not that rare in Nigeria, just maybe mainly misdiagnosed or mainly not diagnosed.
Dr. Fakonda.
Okay, you should know the call again. We don't have much time. We only have 10 minutes. We have to end the meeting soon.
Yeah.
Let's go to the other questions.
Okay. So I'd like to ask Mary P. Igwe. Oxygen therapy is actually a treatment, it's part of treatment for pulmonary hypertension. And what are the challenges and opportunities in assessing this treatment at home? Hello?
Yes, hello, I can hear you.
Okay.
One of the challenges is very limited oxygen in Nigeria. That is oxygen plants in Nigeria, because of how expensive oxygen is. So there are only very few people that can even have the privilege of using an oxygen at home or using an oxygen in the hospital. So these days it's very difficult for doctors to even recommend the usage of oxygen at home, except it's very much needed. Mainly what they do is you get to the hospital when you need the oxygen, get to the hospital, use the oxygen. If your oxygen level gets to a particular, maybe gets better to a level that is okay for you, then they send you back home and all that, even when they know that you need oxygen daily. So a lot of Nigerians cannot afford the usage of oxygen at home. That is why it's difficult to use them. And aside from that, there are risk factors associated with using oxygen at home as well. Like there needs to be a very open, a very good environment. The room needs to be ventilated enough. It doesn't have to be a stuffy environment or a stuffy place. Especially maybe if you live on the island with a very good atmosphere, a very good environment, it's okay. But then most people living in airtight places or people living in a very tight corners is not advisable because these oxygen cylinders can explode due to heat, overheating, and all of that. So there needs to be a very close watch with people using oxygen at home.
All right. So you mentioned that oxygen is very expensive. So for the information of everybody on this platform, so for the rather the benefits for everyone on this platform, I'd like to ask like how much do you acquire oxygen and what amount do you need so that people can know the gravity of this treatment? Yes.
Oxygen, though it depends on the hospital or the clinic you're using. I remember a certain time that oxygen was about 10,000 naira, 10,000 naira, that per hour or so. So I have a portable oxygen. I don't really have I don't really refill my oxygen cylinder. So I would not know, it's been a long time, so I would not know exactly how much it is now. Hello?
Hello, Ibuku. Okay, I think she's gone again. Okay, thank you very much, Mary,
Oh,
for that.
Jesus. I
Ibuku, are
did
you
not know
there?
that I was muted. I did not know I was muted. Okay. So, as I was saying, that we have, because of the limited time we have on this platform, I'd like to thank everybody for starting with us and for staying throughout the program. But before we go, I'd like to ask one more question, or should I ask both last questions?
Yes, please ask.
Oh, okay. So I'd like to ask the second to last question, which is that what role does pulmonary rehabilitation programs play in overall management of pulmonary hypertension, and are they available here in Nigeria? I'd like to throw this question to Dr. Emmanuel. I don't know if he's still on the call. Hello.
Yeah.
Okay.
Hello.
Yes. Thank you, sir.
Yeah. In view
Hello, sir. Can anyone hear him? No. All right. So I think, oh, you can hear him. I think we just skip to the last question, and when his network is the reception at his side is much more better, it would answer that question. So I'd like to throw this question to everyone on the platform. Like, do we have any success stories or examples of patients effectively managing pulmonary hypertension well in Nigeria? Of course, we have two champions here with us on the platform. But aside them, do we know anyone who is effectively living and managing this condition well? And if we do, I would like us to also share their stories in this ample amount of time that we have here on this platform. Anyone? So if we don't have anyone, I think Miss Ayotunde Mitogun or Mary P. can as well just share the stories.
Okay, so when I call myself a success story, actually, I don't know if I call myself a success story. I've been through a lot and I've had a lot of ups and downs, but so far, 10 years in Nigeria, I never expected to actually do 10 years. Yeah, but I'm doing okay. And this year I was actually very, very sick, and I started using last suit and Tofakunda as part of the doctor to manage me. And I think I've been doing so well. I think I've been doing better since I started using last suit. I know a lot of people always have lots of. I think I was one of those people that was like, oh, teaching us tools, a lot of stress, a lot of patience. But I think, yeah, I would say I'm a success story so far because I've actually lived 10 years in Nigeria with hypertension. It's not easy. It's not easy at all. I know. Getting your medications, you move from use different hospitals. I had to then go to India to get treatment. But yes, I think the most important thing is just being an advocate for yourself. I think I know we spoke earlier about getting support and resources from doctors but I think you as a patient you have to do this yourself too. You don't just sit down and expect people to give you that too. You have to also read a lot and learn about the resources and how to do for yourself and also how to be better advocate for yourself. So yeah, I think that's what I'll say.
Thank you very much, Ms. Ayotunde Omitogun. That was an amazing and inspiring short story. I'm glad that you have made it so far, and I'm
so
very
if we can throw the question of the pulmonary rehabilitation program, somebody else, Dr. Fakunda, if it's okay.
All right. Dr. Fakunda, are you still with us, ma?
Yes, I am.
Okay, so I'd like to throw this last question to you, ma, if you don't mind. What role does pulmonary rehabilitation program play in the management of pulmonary hypertension? And are they available here in Nigeria?
Okay, so let me start with the second one. Yes, pulmonary rehabilitation in a way is available because pulmonary rehabilitation is broader than just breathing or physio. It involves nutritional counseling, psychological support, patient education about the condition, and then some education about the treatment, and it's multidisciplinary. But
Please, ma, you're not quite audible, ma.
Hello?
Okay, this is much more better, ma.
Okay, so we have a cardiopulmonary physiotherapy unit at my facility, and they have a structured program to administer chest physiotherapy and exercise strengthening rehabilitation from the physiotherapy units, especially. However, like I've tried to say before, we don't have so much experience with pulmonary hypertension or PAH, especially. So I'm not certain we have a structured program, but when we have more people that need this, it's something that we can work. We have close partnership with the physiotherapy, the chest physiotherapy unit. So it's something that can be made accessible for those that need it. Yes. So there's pulmonary rehabilitation is available.
Yeah, yes, ma. And I also asked about the effectiveness of rehabilitation in the management, ma.
So I won't be able to comment on that because we don't have so much experience with sending pulmonary hypertension patients for pulmonary rehabilitation, unlike COPD and our other patients with other respiratory conditions. So for now, I can't really say. I mean, depending the time we have more patient volume, and then we're able to see the outcome of and be able to assess the need for it, and then see the outcome in those that have it. So for now, in our own practice setting, I can't really speak about the role of pulmonary hypertension in pulmonary hypertension.
All right. Thank you very much, Ma.
Thank you.
Thank you so much, Ma. So before we round up, I'd like to know if Dr. Emmanuel is also on the call. I guess he isn't. I'd like to thank everybody for staying tuned with us. It's been such an amazing knowledge filled 2 hours plus on this platform. I'd like to thank Dr. Yedika, do you have something to say?
Sorry, I just wanted to apologize. I thought it was 9 to 11. I didn't know that it was 8 to 10, our time. So I had to work. So I really apologize. But just a final thing, if you're in Lagos, there's a guy at last week called Oladimeji. We work very, very closely with him. It's not a very expensive place. So he does right-hand cuts, Oladimeji. He does left and right-hand cuts, and it's a lawsuit, right? That's a public facility. So he's a guy that we work very closely with, because we have a lot of our people who come to Nigeria and work with him. We have a lot of confidence in him. We cannot speak highly enough about him, and he's able to do this procedure, right-hand cuts, to diagnose any patient you need. So it's somebody that I would consider getting. Then I think that Dr. Tomitope and Dr. Nkano, if they do pulmonary hypertension, I think that you should take their names and promote them, right? In your pulmonary hypertension communities, let them know that these are the experts on ground. I think that that is how we as advocates can improve the field. So that was just my final thing, and I'll shut up.
Thank you very much, sir.
Sorry for cutting in.
Okay.
Yeah, I just wanted to add that yes, Dr. Oladimeji is my very is my chief, like to refer to our senior colleagues in our practice. But I still wanted to say that, I mean, the right haircut, like I said, is being done at our facility by Dr. Oladimeji, but it is still really very expensive. So most times, if you have 10 patients that you are suspecting and you send, it will probably be just 1 out of 10 that will be able to eventually afford to do the right haircut. So we still need funding and advocacy.
So how much is it?
So it's about 600,000 naira now.
100?
That is a lot of money.
600.
Yes.
For right haircut?
Actually a lot of money. So majority of the patients can't, they end up not being able to afford. I mean, the moment you are even trying to prepare and explain, that's the last time they're going to see them in clinic. So it's still really quite not affordable for a large number of patients.
Thanks for educating me. I appreciate the education. Thank you.
All right. Thank you very much, Dr. Fakonda. Thank you, Dr. Oyedika Lonze. Thank you, Dr. Emmanuel. And I don't know if Miss Ayotunde Omitogo have any closing remarks for us.
The questions.
Yes?
Dr. Fakonda.
Yes.
So those patients that do not have a right heart catheterization, they don't go into treatment.
No. So it just makes it difficult for us to actually really know the people that have PAH amongst our pulmonary hypertension patients. So from the echo, it's suggestive, but there's some people that may still have left heart disease that may not, for some reason, really, they may not really have reduced ejection fraction on the echo and some other things until they do the right heart cuts. And sometimes, for instance, like there's some patients too that their echoes might be difficult, like our typical COPD patients that have a lot of emphysema and hyperinflation, and then we're not so sure if is COPD that is bad, or it's the pH. So it's just, it makes, because if you're going to have a pulmonary hypertension registry, the diagnosis is good, it's confirmed, and then you're able to also know the physiologic abnormality in that individual to tailor the treatment. Because the truth is that most of the pulmonary hypertension medications, they are mostly for the group 1. So meaning that you really need the right heart cath to actually make the diagnosis for group 1. So it's still difficult. Yes, we are able to rely on echo for the other groups, but for now, it's still a challenge, being able to stick out our chest and say that, oh, this person has PAH without the right heart cath. But I must say that we have patients that have been getting right heart caths done. I mean, we've had quite a number, but these patients are mostly the ones that have group 2, group 3. We've not really had, at least so far so good, I've not really had a young patient that I was strongly thinking of PAH. I've not had anyone like really go ahead and do the right heart cath for me to confirm the diagnosis for now.
Sorry, I hate to hijack the conversation, but Dr. Tomitope, what you're saying is really important, right? So if you have patients who you're sending right heart cath, I don't know how many you have, and I don't know if you're interested in publishing, but if you're not,
I am.
So I think that we can get those patients, right?
Okay.
I think the world wants to know, right? What are you getting on right heart cath? When you send these patients, how old are they? I don't know how many you have, but I can think of a couple of journals, if you have the echo and right heart cath data, who are really desperate for data from West Africa.
Okay.
So yeah, so
I'm
I think
very
that
much interested. I think myself and Dr. Ladimeji are actually partner on research. Like currently we're doing a pulmonary embolism intervention kind of registry documenting that. So we're interested in exploring pulmonary hypertension as well. It's just that because the right heart cath, the cardiac catheterization lab is a public-private endeavor. So we've tried to engage the private partners to see if there could be some form of price reduction, but that hasn't been so successful. So, but something we're really interested in that, really.
And you're in the same group with Oluwaseun Okunuga, right?
No, Shokunuga. Yeah, well, I mean, we're in internal medicine, but she's cardiology and pulmonology, but we work closely together.
Yeah. So, because she's also interested in research. So I'm just thinking that, again, hate to hijack the conversation, but I think between your bright mind, we can get something started.
Yeah. I understand.
Okay.
Thank you.
Okay, thank you very much. It was such a wonderful and insightful session. Thank you so much for joining. And if there's anybody who has a question, let me check. Okay, no question. And I think that's it. Ibuku, are you there?
Yes.
So thank you to Ibuku. Thank you to Dr. Papunda. Thank you, Mary, so much for sharing your story. Thank you to Dr. Emmanuel Campo, and thank you so much, Dr. Oye Dika. Thank you so much for joining this meeting. Truly appreciate. So Ibuku, yeah.
All right. So thank you everyone for joining us, for staying tuned. Thank you for your comments and your questions. And we also thank our panelists for honoring us with the invitation and for the clarifications, as well as also creating awareness and educating us on the on particular highlights of pulmonary hypertension. So I hope that we have listened and we are much more educated, and we can also in our own space create awareness about pulmonary hypertension. It doesn't have to be World Pulmonary Hypertension Day, and we can as well do our bit to help patients and celebrate patients who have this medical condition. My name is Ibukolo Afalari. I am your host for today, and do have a lovely evening and an amazing weekend. Bye.
Ah, it doesn't hear.